All right, everyone, let's go and finish up this last section here. So next up, we're going to talk about ventricular tachycardia. You can see here in the middle of the screen, I have two different types of ECG strips. So this is a life-threatening ventricular arrhythmia. It can be wide or narrow complex. So if we're looking at these, I didn't actually provide a good example, but we can see that we have a polymorphic or a monomorphic. So if we're looking up here, monomorphic, all of these QRS waveforms, all these waveforms on this strip here on the left-hand side here are all the same. Looking on the right-hand side here, we can see we have polymorphic, so we can actually see that there are different shapes of QRS waveforms here. All right, so this is an example of polymorphic. Ventricular tachycardia is defined as greater than 3 consecutive wide QRS complex that are greater than 120 milliseconds, and beats of the ventricular origin with a rate of greater than 100 beats per minute. Okay, so we have a rapid heart rate greater than 100 beats per minute, so tachycardia, and we have greater than or equal to 3 consecutive wide QRS complexes. Okay, um, some causes of monomorphic can be prior ischemia, cardiomyopathy, hypertrophy, or cardiac surgeries. They can also be idiopathic, meaning that this is a cellular response, so this can be a conduction issue as well. Polymorphic causes can be an acute myocardial infarction or some sort of disorder in the ion channel, so affecting potassium, sodium, calcium, chloride. All these different channels can be affected, causing a polymorphic ventricular tachycardia. Okay, um, there are differentiating SVT and VTAC is complex. I don't have the time nor the skill set to really go into differentiating these, so I'm just going to acknowledge right now that I'm not the person to teach this to you. If you would like to read more about it, yet again, I highly recommend looking at Life in the Fast Lane, just Googling SVT versus VTAC, know the difference. I think there will be an article that will pop up talking about the differences. Like I said, this is complex in nature, not complicated, but it is complex. There are many factors that go into it, specifically like measuring the differences between the different waveforms. Okay. Note, if the patient has VTAC and has no pulse, we need to initiate rapid defibrillation CPR. Okay, so there are two shockable rhythms. There's VFib and VTAC. If you have pulseless VTAC, this is a rhythm that we can defibrillate. Okay, this goes into ACLS. If you have not taken ACLS yet, you will need to when you become a nurse. Okay, so this is a little bit introduction to ACLS. If they have no pulse, start CPR. Get going. Okay. But the difference between a BLS and ACLS providers, we can actually recognize rhythms. Okay, we don't let the defibrillator do it for us. Okay, so is the rhythm shockable? Yes, because it is VFib or pulseless VTAC. So we can immediately defibrillate. I hate using the word shock. Let's be more educated together and say defibrillate, okay? Because we're not just shocking them, we're defibrillating them, okay? We're going to continue CPR and make sure we gain IV or IO access, and then now we're going to reassess, is the rhythm shockable? Okay, can we defibrillate this? If yes, because it's still VFib or pulses VTAC, we're going to defibrillate again, continue CPR, and administer epinephrine every 3 to 5 minutes. And then if we have a provider available, start getting that airway in and look at capnography. Remember, gold is good if we're doing colorimetric. Then we're going to reassess. Is the rhythm shockable? Yes. Defibrillate. Now we can do CPR and give amio or lidocaine. So that is kind of the pathway for pulses VTAC and VFib, which would be the next thing we talk about. Okay. Kind of going down asystole PEA. We do not defibrillate asystole or PEA. There is no electrical rhythm to reorganize. Okay. So all we're going to do is epi CPR, epi CPR, epi CPR. Okay. But if we get into a defibrillable rhythm, we can defibrillate. Okay, so just consider that. If every crash cart, every ambulance is going to have a card like this and a backside that shows our other rhythms on what to do, like bradycardia, SVT. It's going to show everything that you need to do. It's going to show you how to do CPR, biphasic versus monophasic, your drug therapy, so epi, amio, and lido are going to be your go-to medications for this side of the card. Airway, what you're looking for. ROSC, what to do. There's actually in the ACLS book, there is a whole section of ROSC, looking at like hypothermia treatment and well, where to go from there, and then reversible causes. I want you guys to remember H's and T's. So we have hypovolemia, hypoxia, hydrogen ion, so acidosis, hypo or hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, and thrombosis, whether pulmonary or coronary in nature. Okay, so this is a good little introduction to ACLS for those who have not gone through it, and I'll be breaking down a little bit of this here later on. I'm not going to be talking much about pharmacology because that is a whole independent video on itself. Okay. Looking over here, let's look at our monkeys. Let's look at our monkey strips here. What's going on here? This doesn't look too good. We got three different things going on in one strip. All right, so let's take a look at this first section here. I highlighted in yellow. The monkey's covering up the answer here. So take a second, look at what you got. What do we got here? We've got narrow complex tachycardia. Okay, so the QRS waveforms are narrow and we are in tachycardia. There's many beats in there. All right, now we're just angry. What happened here? We are in polymorphic ventricular tachycardia. Okay, we're getting worse here. This isn't any better. So polymorphic, many different shapes here, and it's definitely ventricular in nature because all we're kind of seeing is those QRS-like waveforms, and it's tachycardic. Okay, and now we're in the oh no. We got VFib. We gotta do something, right? So VFib is one of our defibrillary rhythms. If we're in this ventricular tachycardia and there's no pulse, that is also we can defibrillate that. Okay. But I'm gonna say that this person is unalived currently. Okay. I put this on here to just show you a little bit of how informative reading ECG rhythms are. Okay. So kind of looking at the shape, we've got epsilon waves. I think there's a delta wave, which is indicative of WPW syndrome, which is, I'm not going to be able to get into it. But hyperkalemia and hypokalemia, I can talk a little bit about it. So if we have tented T waves, if there's a finger pulling those T waves up, we're looking at hyperkalemia, and if those T waves are brought down, we're looking at hypokalemia. I can talk a little bit about that. Intracranial hemorrhage, this is actually a really good one. So if this patient's having a hemorrhagic stroke, and we can see we have this huge, giant T wave inversion. Look at how think you could fit your whole brain in there, right? Okay, so if we can fit our whole brain in there, we're having a intracranial hemorrhage. We're having massive increases in intracranial pressure. So I want to inform everyone that EKGs can show a lot more than just what's going on with the heart. Or what is going on in the heart. This is another good example. Massive pericardial infusion. So we've got fluid within the visceral space around the pericardial or within the pericardial sac. So you can see, look at this first QRS, right? So it's low voltage, right? So it's low, it's not as high. And then next one, we can see that there's a high QRS, that R wave is way higher. Okay, and if we think about it, if we're thinking about the muscle beating within that pericardial sac and it's pushing against fluid, we're going to have deviations in the amount of depolarization that's going on. So you'll see it on an ECG strip. You'll have a low R wave and then a high R wave, a low R wave and a high R wave because it's pushing against that fluid that's within there. So that, again, Life in the Fast Lane, I should get sponsored by them, but very good reference material. So let's get out. Let's go into our another one, which is the VFib, and that is instantly, we should know this is instantly one of our defibrillary rhythms, okay? So we see chaotic, irregular deflections of varying amplitudes, okay? So there's it's a running joke if you ever take an ACLS, but if you ever see like PEA, some people would joke and be like, oh, I see fine VFib. That's just kind of a running joke, but we have coarse VFib, and then we've got fine VFib, kind of left to right. You can kind of see a little bit of coarse VFib over here, and then fine VFib on the right, okay? There are no identifiable P waves, so we cannot see any P waves. There are no QRS complexes or no T waves. What's happening is the ventricles are fibrillating. They are just making a bunch of noise, not doing anything in particular, and there's no cardiac output. Okay, the rate can be 150 to 500 per minute. So we'll see that little inflection, those depolarization waves here going on at about 500 per minute. And yet again, I was talking about coarse to fine, so the amplitude can decrease with duration. So what's happening here is we go from coarse to fine. Those heart muscles are starting to give out. So we're going to have this is getting progressively worse, and we're going to end up in PEA or asystole here soon. Ventricular fibrillation, VF, is the most important shockable cardiac arrest rhythm. It is very reversible. We can reset this very easily by rapid defibrillation, okay? And this is really important because if these ventricles, which are pushing the fluids, our blood out into the body to perfuse our tissue, we do not have effective cardiac output. Okay. So as far as causes, we can look at for cardiac reasons, we could have a heart attack, cardiomyopathy. There are many different types of cardiomyopathy, dilated, hypertrophic, and restrictive. I don't have time to go into that. Channelopathies, so yet again, we're having an issue with one of our ion channels within the cardiac myocytes. There could be stenosis of the aorta, so that aortic is really stiff. It doesn't properly contract, or it doesn't dilate and then contract again. Aortic dissection, or the most fatal of them is a AAA, an ascending aortic aneurysm. So we can have a dissection of that. Myocarditis, cardiac tamponade, so fluid around the heart, and then blunt trauma, so coma cordis. Commotio cordis, let me find our sinus rhythm up here. So the T wave here is very sensitive. So if there was some sort of blunt trauma, specifically in this upward inflection of the T wave, if you were to have blunt trauma to the chest here, we could actually set you into VFib or some sort of other arrhythmia, okay? But most commonly it's going to be VFib, and that's called commotio cordis when we have some sort of blunt chest trauma right over the heart on the left side of the sternum, can send you into VFib. There's been a couple notable cases of baseball players actually getting hit in the chest at a perfect time with a baseball or a bat, and sends them into VFib. Looking at respiratory, we could be caused by tension pneumothorax, a PE, pulmonary hypertension, even sleep apnea. And just think, if we're having lack of perfusion to those cardiac myocytes, we could send them to a dysrhythmia, and we could have bronchospasms or aspiration. Okay. Neurologically, we could have a seizure or or a cerebrovascular. Wow, I'm completely spacing. Sorry, guys, but a CVA. Um, so anything that's going to affect the neurologic system can have impacts on the cardiovascular system and systemically. So this could put you in VFib as well. Environmental, if you've been electrocuted, so electrical shock, you've had drowning or hypothermia, that's going to affect the heart muscles. And then sepsis as well. We're becoming an acidotic environment, and this can affect the heart muscles. Next up, we have, excuse me, one sec. All right, sorry, my phone is ringing. PEA, there's no palpable pulse noted. Monitor strip can appear as a multitude of things as there is still electrical activity, but there is no pulse. I want to remind you, we treat the patient, not the monitor. If they have a pulse, or if they have no pulse, but there's a rhythm on the monitor, they still have no pulse. We need to begin CPR, and we're going to follow that right-hand side of the ACL algorithm. So CPR, epi, CPR, epi, CPR, epi, and we can even throw an airway in there if we have the availability with a paramedic or an advanced APP, advanced provider practitioner, okay? Now we're going to go down to the causes of PA. We're just going to go to our H's and T's. It says 4, but there's more. But the four primary ones: hypovolemia, hypoxia, hyper and hypokalemia, metabolic disorders, hypothermia, toxicity, tension pneumothorax, tamponade, and thromboembolism, where there's MI or PE. Okay. Asystole, nothing. There's no electricity, no pulse. We cannot defibrillate, no electrical activity. There's nothing to reset. When we defibrillate, we're resetting the electrical activity. There is nothing to reset. This person is in a bad spot. Okay, so yet again, CPR, epi, CPR. Talking about different types of defibrillators, there's monophasic and biphasic. So mono meaning one. So the delivery of joules or electricity through the heart is going from the ventricular pad. So on the left, depending on the type of depending on the type of defibrillator have, it's going from the either posterior to the anterior, or it's going from the left mid-axillary to the right sternum. Okay, so it's going from the ventricles up to the atriums. Okay, if it's biphasic, it's going to go from ventricular to atrial back to ventricular. Okay, so that's kind of the difference between monophasic and biphasic. There is a difference, and most modern monitors are able to be configured in whichever need you, whichever way you want to deliver it, depending on the provider. Us as ACS providers, we should strictly stick with biphasic defibrillation. Okay. This is a little bit of an extra credit section here. I would like to talk about it. DSD, or double sequential defibrillation. This is a current area of study, and this could be the future. Okay. So basically, what we do is we place the patient on two sets of biphasic defibrillators. So we'll have two separate defibrillators, and this can only be done by a provider, usually a cardiologist. They're in an ER. There are some EMS services with the approval of the medical director who are allowed to do DSD currently. Okay, it is proven to have patient outcomes and better at converting patients back to a stable symptomatic or asymptomatic rhythm. Okay. Um, so they'll be hooked up to two different pads. The pads won't touch. There's a lot of positioning things that could be done depending on what type of arrhythmia they're going through. Um, they can be done as a close to simultaneous as possible. So what'll happen is one provider will press both buttons simultaneously, and there's always going to be a little bit of delay, so it's going to be as close to simultaneous as possible. Or there can be a minor delay, and this is done with two providers. So one will push one button, one will push the other. Let's say 1, 2, 3, go, and they'll push the buttons, and there's a little bit of a delay since it's not the same person. Okay. Synchronized cardioversion, we covered this a little bit in SVT. So this is a low energy defibrillation given specifically on the R wave. Okay, so we're timing the delivery of this energy specifically to the R wave to try and convert them back into a non-life-threatening arrhythmia. Okay, my biggest tip for you, I've seen it happen: press and hold the shock button on your defibrillator. Okay, make sure you press and hold it because we're timing it. If you press it once and it's not on the R wave, it's not going to go off. So press and hold until you hear it go off, or you see it on the monitor strip. Okay. Next, I'm going to go into atrial and ventricular or atrioventricular pacemakers. Yet again, I highly recommend you read about this. I'm going to cover the basics here. But there's a lot more that goes into this. I recommend reading the Pacemaker Types and Selection by Hassan Mahmoud Lak and Amandeep Goyal. So this is a NCBI article that you can read. Okay, I kind of took some of this information from that to just kind of give you the basics. Okay, so we have atrial pacemakers. These are to treat arrhythmias that occur between the SA and AV node. It's in the atrium, so we're having an atrial conduction issue. Ventricular pacemakers, it's the same thing. It's placed in the ventricle, so we have a slow ventricular heart rate, and it will also improve synchrony in the left and right ventricles. This is important for patients who have heart failure. If we have a low ejection fraction, so how much we're ejecting from the ventricles, we want to make sure we improve that as much as possible by increasing the synchrony. Okay, if we have them constricting at the same time, we're going to improve that injection fraction, improve the amount of systole that we're having out of that heart. And then atrioventricular, so we're complete control of the heart rate. Okay, so we're having a lot of conduction issues. This is common in patients who have like AV node ablation. So we're burning out or using radiation on the radiographic spectrum to ablage or burn up that AV node. And we're taking complete control using this atrioventricular pacemaker. Okay. Failure to sense, there's two types. There's undersensing. Let me go and highlight that. And then we have oversensing. Okay. So there's two different types here. So undersensing occurs when the pacemaker fails to sense native cardiac activity. So there's sensors in there, and if it undersenses it, we might not be getting any cardiac output, or it might just take over because it's just not sensing that. Okay, this can result in asynchronous pacing, especially if it's just an atrial or a ventricular pacer. We could end up kind of similar to like a type 3 heart block, where we have complete desynchrony in both the atrium contraction and the ventricular contraction. Causes include increased stimulation threshold at the electrode site. So we're not meeting the the threshold has been raised on that lead basically, and we're not able to meet that threshold. We could have poor contact with the cardiac myocytes, or we could have a new bundle branch block. Remember, we have left and right bundle branch blocks, or there can be issue with the programming of the pacemaker itself. Oversensing occurs when electrical signals are inappropriately recognized as native cardiac activity, and the pacing is inhibited. So we're just we're oversensitive to it. Okay. Um, these inappropriate signals may lead to large P or T waves and skeletal muscle activity or lead contact problems. We can have abnormal signals may not be evident on the ECG, so we might not see this. So I'm going to cover it down here in just a second. Failure to capture. So we're not capturing the stimulus to cause pacing. So this is kind of due to a lack of myocardial depolarization. It's not enough to capture it. There could be electrode displacement, wire fractures, so fracture of the wire due to trauma or just use, and electrolyte disturbances. So we're not sensing that potassium, sodium, or other electrolyte changes. We could also be having an MI or some sort of exit block. Like I said, I don't have time to get into these different types of blocks, other than the ones we covered earlier. Failure to pace. So if we're not pacing properly, it could be due to the output isn't enough to generate a cardiac myocyte contractility. So there's just not enough electrical output. And this can result in decreased or absent pacemaker function overall. We could have oversensing wire fraction, lead displacement, or some sort of other electrical interference. So if we have something that has radio frequencies close to the pacemaker, this can cause a failure to pace. Okay, I'm just going to cover this real quick. There's on crash carts, you should always see a magnet. This magnet is round, usually blue in color. It's hollow in the center. What we can do is we think that there's a failure to pace or some other. Sorry, one moment. All right, I apologize. I apologize about that. So our magnet it's that round circular with hollow in the middle. If we know if there's a pacemaker malfunction or a defibrillator malfunction, we can place that over the site, and it will actually stop the defibrillator pacemaker from firing. And then a interrogator or a cardiac interrogator is a person who represents the company of the defibrillator or pacemaker that's been placed. Um, so every time they get an implant, they will get a card, and that card will be issued to the patient, and the patient is supposed to carry it everywhere they go. Therefore, we can contact their company and get them to come out and take a look at it. And see what the issue is. They have many troubleshooting techniques. They can actually wirelessly connect to the implanted device. Okay. Post-op care for defib and pacemaker implantation. It's always going to be the same as any post-surgical post-surgery assessments. So we're going to monitor the site for bleeding and infection. We're going to note bruising, make sure it's not too much. We're going to avoid immersion in the site to reduce contamination or infiltration of that water. We're going to minimize arm and shoulder activity of the affected arm and wear loose covering over the incision for 1 to 2 weeks. And we want to make sure we prevent dislodgement of those new leads. Okay. Interventions for non-lethal versus lethal arrhythmias. I'm just going to keep it simple. The 5 functions of a heart start monitor, and then we also have pharmacology, which I'm not going to cover. The 5 functions are monitor, defibrillate, pace, synchronized cardioversion, and AED. If we're having a myocardial infarction, the next topic is myocardial infarction. This is a heart attack. This is a decrease or loss of blood flow to the heart. This is fatal. Okay, so we need to treat this quickly and efficiently. A common cause is going to be coronary artery disease, but we could also have some causes are smoking. We could have high lipids. We could have hypertension, diabetes mellitus, obesity, depression, anxiety, lack of nutrition, so we're not consuming enough fruits or vegetables, inactivity, and alcohol. I know some studies are actually I think it's called Interheart. They're pushing away from alcohol as being a cause of MI. There's not a very strong association, but I know smoking and proteins have a strong association, higher than alcohol. When we're looking at etiology, we can look at first. Let's go over here to the right-hand side here. So we can see if we're looking at the heart here, we can see that we have all these major vessels covering the heart. So we have the right coronary artery, the distal right coronary artery, the left anterior descending or LAD, the circumflex, and the left main coronary artery. And there's inferior arteries as well. When we're looking at this, I drew on here on the left anterior descending. We have occlusions here. So if we have an occlusion down here on this one, we're going to have necrosis and failure of function on this section of the heart, and same thing here. So depending on where the occlusion is, we will have a change and loss of tissue or ischemia in these regions. All right. So kind of going back, we're going to talk a little bit about ST segment elevation in two continuous leads. So when we're talking about ST segment elevation, we need to really understand what we're looking at. So down in these little red areas here, we can see different types of ST segments. So we can see here, unstable angina is minimal occlusion. There's no necrosis of the heart muscle here, okay? So in this section here, we can see that there is a depression in the ST segment. This isn't a super great example, but this is what we might see, those inverted T waves, okay? Over here in NSTEMI, so non-ST elevation myocardial infarction, there's a severe occlusion for blood flow, okay? And so what we're going to see is limited tissue necrosis, and then the vasculature is actually going to be necrotic as well. And we can see that by these widened segments here, okay? And then over here for a STEMI, ST elevation myocardial infarction, we have a complete occlusion of all blood flow, and we're actually going to see necrosis of a large area. And this is what a STEMI is going to look like on an EKG. So we're going to have a very high ST segment. It's basically going to go right from the R wave to a T wave that's above the R wave, okay? A good way to remember the difference between a ST segment, so a STEMI versus a depression, so elevation versus depression. A elevation is indicative of having a active or increasing myocardial infarction, where a depression is usually indicative of having had one occurred and it is completed. Okay, so the occlusion is not getting any worse, and we're starting to so and so improve. Okay. Um, when we're looking at laboratory values, one that is very important is going to be troponin. Okay, there's a couple different types of troponin. There's troponin I and troponin T. The most common one you're going to see is called a troponin I. It's just used like that because of one of the laboratory analyzers that are used is called an iStat. iStat cartridges measure troponin I, and iStats are very easy to use, so they're probably the most frequent. So troponin, we have these myosin fibers and actin fibers. These fibers are responsible for contractility of the heart, or of muscles really overall. But in cardiac muscles, these troponin are very important. We have a troponin and tropomyosin. So what's going to happen is these myosin molecule heads, these heads here, are going to basically crawl up with these protein molecules are going to crawl up by binding and unbinding to these actin and by mechanisms used with the troponin. And so if we see troponin within the bloodstream, so if we see it within the bloodstream, we can say that there's been troponin released from the cardiac myocytes into the bloodstream. So if we have free troponin in our blood and it's increasing, okay, so if it's increasing up, that means that we're having cardiac death occur. So if there's an increase, so trop is increasing, cardiac death is occurring. Okay. If trop is decreasing, cardiac death has occurred and the event is improving. All right. So what are our trop values? Okay. Stroke values will obviously depend on the equipment and the facility you're at, but yet again, referring to the ISTAT, that's the most common one. A positive troponin is going to be over the range. So positive trope can be over 0.08. So anything over 0.08 is going to be a critical, and this indicates a positive troponin. Okay. The currently certain heart agencies like the AHA are currently examining what a positive troponin is, and some new findings are showing that anything over 0.49 is actually going to be the new value for a positive troponin. No, I did that backwards, but so 0.49 is going to be a positive troponin. So there are some changes. Oh, 0.049. There we go. So 0.04, basically 0.05. We'll round it to 0.05. So anything over that is going to be a positive troponin in the future, just kind of based off the AHA guidelines. So just kind of keep that in the back of your mind. If you're seeing 0.05, 0.06, 0.07, you're not at 0.08, we are having some sort of cardiac issue going on. We want to keep that in mind. So the most important thing is trending. Okay, so if the troponin is continuing to go up, that STEMI or NSTEMI that's going on is actually getting worse. Where if it's going down, remember the trend. If it's down, like SC depression, the event is over and everything's improving. Doesn't mean the heart's in a good spot, but it's getting better. Okay. When we're talking about, if we want to talk a little bit, I'm just going to give you a little extra here. So if we're talking about like epidemiology, we can kind of look at the rate of occurrence. So what would you guys would say, or who would you say, male or females are more likely to get a myocardial infarction? If you said male, you'd be correct. So in non-Hispanic whites, we're looking at about 4% male to 2.4% female. If we're talking non-Hispanic blacks, we're looking at 3.3% male to 2.2% female. Hispanics are going to be 2.9 male and 2.1 female, and then non-Hispanic Asians are looking at 2.6 male and 0.7% female. So you can see we have an obvious trend in favor of, I guess not in favor, but incidence in males. So definitely keep that in mind. And then the most common occurrence is going to be in non-Hispanic whites. So for treatment, I thought I put treatment. Here we go. When we're talking about treatment in the acute management, we want to make sure we can prevent that myocardial infarction getting worse. So we can do a couple of things here. So we can do what's called a PCI. Okay, so this is the procedure where with a oh, I'm completely forgetting what the acronym is called, but it's when they go in and try and reperfuse the local area. Percutaneous coronary intervention. There we go. So it's when they'll go in through the femoral artery or brachial artery, and they'll go in with some sort of instrument, and they can actually remove that, do a stent, do a bypass. There's a couple of different, or they can use fibrinolytics directly on the site to try and break down that clot. We can also hit them with MONA, so morphine, oxygen, nitrogen, or nitroglycerin, aspirin. The biggest thing is with MONA, it's more like MONA. So just be careful with oxygen. We titrate to effectiveness because oxygen is a vasoconstrictor. So if we're constricting down those coronary arteries that are already occluded, we can make the issue a lot worse. Okay, beta blockers, they reduce heart rate, reduce blood pressure, and reduce contractility. So basically, what we're doing is we're reducing the amount of cardiac load the heart is required, and by doing that, we're not going to have as much metabolic waste, and there'll be less an ischemia and necrosis going on. So we're reducing the amount of load on the heart, so it doesn't die as quickly. All right. Aspirin is always a very good first line drug. A lot of EMS providers, if they're picking up someone in an ambulance, they're going to go ahead and slap them with the 4-baby aspirin. All right. Just make sure, one thing to remember, there is a difference between chewable aspirin and enteric-coated aspirin. So if we're giving the chewable baby aspirin, it's going to be a dose of 324. And if we're giving the enteric coated, it's going to be a dose of 81. So just remember the difference between enteric coated and the chewable tablets. Okay, and this has to do with how the aspirin is absorbed and over a period of time. So the enteric coated is going to be a little bit more effective at actually being absorbed into the bloodstream, whereas the chewable is less effective. So just remember absorption, uh, digestion, absorption, and then metabolism. Okay. And then we can also give a P2Y212 in patients who are hepatically stable. These medications have to be oxidized within the liver to be effective. And these medications work by inhibiting the ATP induced platelet aggregation. So we're preventing those clots from becoming larger. Okay. When we're talking about blood flow here, when we're looking at the heart and realizing that wherever this tissue necrosis affects, it's going to affect the output. We need to understand how the heart works. Okay, so we have the superior vena cava and the inferior vena cava. These are taking in the venous return blood supply. So this is deoxygenated blood. Remember, not all the blood has been depleted of its oxygen, but it is returning the carbon dioxide back into the right atrium here, okay? So it's going to come to the right atrium, pass through the tricuspid valve into the right ventricle, and through the right ventricle past the pulmonary valve into the pulmonary artery, which is going to feed our left and right lungs respectively. And from there, they're going to return in our pulmonary vein, which is our only vein that carries oxygenated blood, back into the left atrium, and then past our bicuspid valve or mitral valve into the left ventricle. And then from here in the left ventricle, we're going to go through the aortic valve, which is one of our semilunar valves, up into the aorta, the arch of the aorta. These are going to be like our subclavian veins and serve into like subclavian arteries and serve into like our carotid arteries. So these are going to feed our upper extremities and our neck into our head and brain. So these are very important. And earlier I mentioned about like a AAA and ascending aortic aneurysm. So if this basically what happens is the inner lumen, remember our arteries have 3 layers of lumens, right? So 3 layers of tissue. And if that inner artery peels off in the downward direction, blood will start to flow inside of it and will peel away from the wall. And what can happen is if it peels up into the aortic arch, we can have a complete occlusion of the aorta going downward, okay, downward into the thoracic abdominal cavity. Or we could actually occlude these and we could have an ischemic stroke because we're not having arterial blood flow into the brain. So that's a little bit of a blood flow. So if we have a left anterior descending, which is commonly called the widowmaker, if we have an occlusion in that, if we have a myocardial infarction in that region, the most important portion of the heart, the left ventricle, which pushes the blood out into the body, if we have that, we're going to be in big trouble real quick, and we need to do something fast to save that left ventricle. So as far as symptoms go, um, men, women, and elders, they all present differently. So men are typically going to have a diaphoresis, chest pain, neck and jaw pain. They can also have shortness of breath and heartburn. Women typically have dizziness, shoulder blade pain, shortness of breath, indigestion, fatigue, and sleep disturbances. And our elders will have dyspnea, syncope, back pain, weakness, confusion, altered mental status, and heart failure, if I could spell correctly. So, looking at these, although these are the generalized categories and symptoms for a myocardial infarction, this is another thing kind of like PE where they can be vague and non-specific, and a lot of times they can be referred pain. There are a lot of other parts of the differential diagnosis that we need to consider, like a PE in the first place, or it could just be something like GERD, or it could be something to do with the lungs. So just keep this in mind that these are good baseline symptoms, but there are many other symptoms that can occur. And usually, if you're having a myocardial infarction, there's also some sort of secondary disease process that's occurring as well. Moving into treatment, we kind of already talked about all this, so let's skip that. Long-term treatment is what I meant to hit. So lipid lowering, so lowering those fats so we don't have as much occlusion going on in here. If you're ever interested in learning about statins and my personal opinion on it, you're more than welcome to approach me on it. Aspirin, so we're preventing coagulopathy from going on. ACE inhibitors, so angiotensin converting enzyme inhibitors. We should be pretty familiar with what ACE is. The reason we're doing this is to reduce the amount of cardiac load on the heart, so we prevent death from occurring as frequently. And since this is long-term care, we want to reduce the rate of vasoconstriction. And if we reduce the vasoconstriction and we have these more dilated, there's less possibility of occlusion occurring. Same thing with beta blockers, but we need to be aware that this is going to be targeted for people with who have a left ventricular ejection fraction less than 40%. And this is just kind of due to if this becomes too permanently damaged and we lower the heart rate and the pressure too much, this pressure that comes out of here might not be sufficient to properly perfuse the heart. So, and yet again, the recurring trend, hypertension medications, another medication we give is like hydrochlorothiazide, for example. Glucose-lowering medications, diabetes is a big risk for tissue necrosis, so let's just keep this in mind. Smoking cessation, nicotine is a vasoconstrictor, and diet and weight control, so kind of lowering these lipids and having a happier, healthier heart, removing that adipose tissue from around the heart. Nursing treatment, it says obtain ECG daily. I would probably do, if a patient is any type of kind of symptomatic, I'm going to be doing ECGs probably as frequently as we do troponins, if not more frequently. They should be on a monitor anyways, so it shouldn't matter too much. Make sure the patient has 2 large bore IVs, and this is for rapid pharmacological management, or if the patient has some sort of cardiac arrest or goes into a cardiac arrhythmia. We're going to monitor those cardiac enzymes, so that troponin I or T, and then we're going to initiate treatment for acute myocardial infarction. So yet again, we're going to hit with MONA, so morphine, aspirin, nitroglycerin, sublingual. We're going to provide oxygen if the pulse oximetry is less than 94%. Like I said, be careful giving oxygen. It can vasoconstrict. And ensure the patient sees a cardiologist. We need to make sure that these patients get follow-up care and long-term care, as they can do things and make sure it's not getting any worse. They even might go and do like an echo or cardiac stress test. We're going to monitor vital signs depending on the stability of the patient or the medications they're giving. It could be anywhere from Q4, Q2, even down to Q30, depending on the severity of the patient. I would say the higher the troponin, the more frequently I'm doing vital signs. We're going to monitor daily weight and urine output. We want to make sure we're getting I's and O's. And then administer heparin as ordered for STEMI. Heparin is an anticoagulant, affects coagulopathy. So we can make that incidence of STEMI less. Okay. If the patient has cardiac catheterization, we want to make sure we check the site, make sure that it's healed properly, and that we have distal-like pulses. So we're going to palpate the pedal pulses or popliteal pulses. MI systemic effects. I'm going to lightly cover this. We'll be looking at lack of perfusion to organs. This can lead to acute kidney injury. We're going to have a possibility of a stroke. We can also have liver damage, and this could also send us to more arrhythmias. Okay. Now that we kind of covered most of myocardial infarction, some of the other differential diagnosis would just be kind of more like angina pectoralis, NSTEMI, PE, or even a pneumothorax are all possibilities. Okay. There are different. When we're talking about complications, there's a couple different categories here. We have like ischemic, arrhythmias, mechanical, embolytic, or inflammatory. So some complications you can have is like a reinfarction, an extension to the current infarction. We can go into like some sort of like SVT or ventricular arrhythmia, like VFib, VTAC. You can go to like sinus bradycardia or have some sort of AV block. We could have a cardiac failure, cardiogenic shock, or we can even have a rupture of the heart. We can also have generate a peripheral embolism, and we can also have pericarditis and pericardial effusion. So there's a bunch of different complications that can occur from having a MI. Now we're going to jump into the pathology of heart failure. So failure of the heart to properly pump blood to perfuse tissue. It's as simple as that. So we're talking about congested heart failure or heart failure. The heart is failing to pump and the body cannot sustain that. So there are different types of heart failure. There's left and right, and diastolic and systolic. Okay, so referring to the directions of the heart, left and right, and then diastolic and systolic, so atriums or ventricles. Manifestations of right-sided. So I have a cool little mnemonic for both sides I found here. So ahead. So we've got anorexia, nausea, weight gain, uh, hepatomegaly, edema, ascites, and distended neck phase or JVD. So these are kind of some signs and symptoms to look out if you're looking for right-sided heart failure or an exacerbation of CHF. And for left-sided heart failure, we have DCHAP, so dyspnea, orthopnea, cough, hemoptysis, adventitious breath sounds, and pulmonary congestion. So yet again, a little bit to look on the left heart side here. Medical interventions used to monitor and treat. So we can do a BNP or BN type peptide. These are peptides that are released when there's cardiac stretch. So if that heart muscle is stretching out, we're going to see BNP in here. And our reference range is going to usually be for a triage meter, which is an instrument we use, greater than 1,000. Or nope, my apologies. This says greater than 1,000. I'll come back to that. I think it actually might be greater than 100. We could do a chest x-ray. CHF is definitely something you can see on a chest x-ray. You can just see it by a shift in maybe the septum, or you can see it as a enlarged heart. We could do an EKG to rule out other secondary etiology of what's going on. We can do an echocardiogram with an ultrasound. Typically, providers in an ER environment or in the field environment will do what's called a FAST one. You can do a FAST exam. You can do a cardiac stress test, CT, MRI, a angiogram and when I say angiogram, I mean a catheter-guided angiogram. Treatment, we can do ACE inhibitors, angiotensin. Man, I forgot what ARB stands for. One sec. But we can also do like beta blockers, angiotensin receptor blockers. I should have known that. Beta blockers. Yet again, we're reducing the demand of the heart or how hard the heart is contracting. The big thing about CHF is since it's so congested, we can actually have demand ischemia because of this. Diuretics and potassium sparing diuretics, so we can force some of that fluid out so there's not as much congestion. We can give digoxin, which increases the contractility, so we're forcing that fluid out so it doesn't have as much stretch. Hydralazine, another blood pressure-based medication. We could do bypass surgery, a valve replacement. So if any one of the cardiac valves are failing, we have regurgitation. This could reduce the amount of ejection fraction we're having. If this is a arrhythmia based, we could do an implantable cardioversion defibrillator. We can also do what's called a VAD, which is a ventricular assist device. This is basically a device that it pumps for your ventricles. They're pretty interesting. There's some cool videos. I believe we saw a video in our first semester here, so we should be pretty familiar. And then we can also do a heart transplant. When we're looking at there are different stages. These are actually based off of the ejection fraction findings and the signs and symptoms the patient's getting. So we have stage A. There are several risk factors for heart failure, but no signs and symptoms. So they're just at risk for developing it. B, there is heart disease, but no signs and symptoms. C, there is disease and signs and symptoms. And then D, advanced heart failure requires specialized treatment. So this is going to be someone in stage D who gets like a VAD or some sort of surgical intervention here. So long term, if these interventions don't improve ejection fraction and the condition worsens, we really need to start considering hospice, because if they can't get on a heart transplant list or there's no hearts available, there's really not much we can do. If we're having a failure of our ABCs, the C is failing, we cannot sustain life here. So this is something we need to consider. Um, Other long-term things is preventing ourselves from getting in this situation in the first place. So making sure we're living a healthy lifestyle, taking our medications as directed, and following, making sure we're following proper care guidelines implemented by our cardiologist. Okay. Lastly, acute kidney injury. I really don't have time to cover AKI, but I do have a good article here. So if you just Google acute kidney injury definition, pathophysiology, and clinical phenotypes by these people here, it'll present a really good article that's well written and pretty easy to follow. Acute kidney injury is not a super complicated topic, so I just recommend you take the time and read up on it. I hope you guys enjoyed this. If you have any questions or further recommendations, please feel free to approach me. I can definitely get you the answer and explain it away. If you need me to re-explain any of this content here, yet again, please just ask me. I can try and rephrase it in a way that might be more suitable for you. I will be sharing this to anyone who asks for the OneDrive file. I will be happy to share it with you so you can view it. And that's about it. I hope you guys enjoyed this, and let's do well in this exam.